2, 1. Please start, sir. We are live.
Very good evening to everyone. I am Dr. Hiren Prajapati on behalf of Aris Life Sciences. Welcome you all in our today's scientific session. That is, we can say episode 9, ninth episode of Krevas Academy. Doctors, you all know that Aris is always a patient-centric company. So we always keeping patient in center when we offer our services. And ultimately, our objective is to improve the outcome of the patients, the health outcome, cardiovascular, and the other outcome of the patients through our different initiatives under the umbrella of patient care initiatives, so-called PCI. And these are the initiatives we can say CGM on call, ABPM on call, Holter monitoring on call, sleep study on call, vascular screening. So these are some initiatives that we have initiated, keeping our patients at the center. And now we are become number one company to providing the patient care for better health outcome. We are not only providing this platform to our patients for improving their outcome, but we also have created the scientific platforms at different forums. Especially the objective with this platform is to guiding our clinicians across India for improving the cardiovascular outcome in the patients, so that their scientific platform will help our clinicians to improve the outcome of these patients when we are providing this platform. And one such platform is called Krevas Academic. So this is our major objective or the motto of creating this platform. And you all have witnessed the earlier 8 episodes of the Krevas Academy, where we have tried to give our best scientific platform for improving the ultimately that will help you in your practice for improving the outcome, cardiovascular outcome of your patients. So the journey started last year with month of April, when we started our first session on Krevas Academic, and that session was on statin, essential for diabetic heart, with our eminent expert panels, followed by the second sessions on the statin optimization, the need of the hour. So in all the sessions, our moderator, Dr. Shah, is consistently there in all the sessions, who has guided and moderated this session well. Third session number 3, that was on month of June, with a battle against the arterial plaque with statin therapy. Followed by the session 4, the jury on SAMS with our expert panels. Then the session 5th, that was on the month of August, with the hidden threat, the low LDL yet high cardiovascular risk, with our eminent faculties across India. And on the month of September, our session was on high intensity statin therapy and unified solution to cardiovascular disease management. While in the month of October, we came with the session intensity matters, deciphering the significance in statin therapy with our eminent faculty. And in the last month, the month of December, we came with the session number 8, that is unraveling the lipid puzzles, the holistic approach to dyslipidemia management with our eminent faculties. So now I welcome you all in the session 9. Again, a very unique and very interesting session because this is a lipid management puzzles aligning the expectation with reality. So what is the reality and what is our expectation? Our expectation from the guideline, from our clinical evidence, and what is the reality there in the clinical practice. So that is what the puzzle we are going to solve with our experts today in this meeting. And they're going to enlighten all of us with this solving this puzzle. So this topic is covered under the mainly 3 subtitles. The first one is the prescription harmony, building bridges for the better patient adherence. Second is the blueprint for the better care. So here our experts going to discuss about the understanding the necessity of the guideline for management of the different conditions, and especially on dyslipidemia. And the last one, very important, is the lost in translation. So here there is a discrepancy in the guideline implementation, the clinical practice. So what could be the reason for that, and what could be a solution? So all these matters are going to be discussed in next 45 to 50 minutes with our eminent experts in today's meeting. So I would like to invite our moderator, Dr. Sanjeev Shah, on this virtual platform. Dr. Sanjeev Shah is a consultant endocrinologist at the Nanavati Max Super Specialty Hospital at Mumbai. He's practicing since last 40 years in the field of diabetes. So I would like to invite Dr. Sanjeev Shah. Over to you, Dr. Shah.
Thank you, Dr. Hiren, for those kind words. So all these 8 months, we have discussed intensively lipid science, statin, arterial plaque, biology and pathology, and the side effects of statin therapy. Today, we are going to discuss primarily still why physicians do not prescribe. So it's more of a clinical inertia. There is success is possible only when patient follows the prescription, takes properly the recommended dose for the recommended period. And lastly, into the philosophy of how guidelines are prepared, guidelines are published, but still physicians do not follow the guideline. So it's a very important aspect of patient treatment. So in the context setting, today I have 3 experts joining with me. I have Dr. Ramesh Dargad, who is a senior consultant physician cardiologist based in Mumbai, affiliated with Lilavati Hospital and Research Center. He is a clinical non-interventional cardiologist with rich academic experience and knowledge. I have Dr. Ashok Kumar Das, who is professor of medicine, professor of endocrinology at JIPMER, Pondicherry. That's a very prestigious institute. And Dr. A.K. Das had been a pioneer in multiple guidelines in the field of diabetology. So he's an important person today. He's also on many national committee policy decisions, and he is going to contribute heavily today on our 3 different areas. With 3 different diverse faculty, lipid science cannot be completed without presence of cardiologists. So I would also invite Dr. T. Govindan Unni, who is professor and head of the Department of Cardiology at Jubilee Mission Medical College and Research Institute in the city of Trichur, Kerala. He is a national and international speaker with 45 publications to his credit and more than 30 years of experience in the field of cardiology. So we have very, very senior 3 different faculties today. And to set the stage, I would just in a single slide highlight the importance of lowering of lipid level, which has an impact on the prognosis and biological mechanisms. The risk of mortality could be reduced by 20% in primary prevention and by 31% in secondary prevention. 3 boxes tell me that longer the treatment, it would be better. Lower the LDL, it would be better. And if you start the treatment as early as possible, the likelihood of a complication would be less. For that, I would give you a concept of lifetime exposure of LDL burden. I would not go into the details of mechanism, how statin would work. If you see in the top corner, if you have a burden of 7,000 milligram with 100 milligram LDL, you are likely to get a CV event by the age of 70. If it is higher than that, maybe much more earlier. But if your LDL is at 70 or below, you would probably not get a CV event for very long period of time. So level of exposure and the duration of exposure would matter. The other 3 diagrams, there is an elegant paper by Dr. Kaushik Ray and Dr. Brandit. Very interesting concept of population health, and a cumulative exposure is very important. The left bar diagram indicates the different degree of risk in the people when you are treating them, and the different degree of reduction of LDL what you would achieve. So higher the risk, larger the benefit. Higher the reduction, larger the benefit. But the difficulty is that our physicians does not follow the guideline. There is a beautiful sentence which I have copied down here, that preventing a cardiovascular disease require shifting a focus from treating the disease after it develops. That's usual concept. But ideally, we should prevent CV events before they happen by slowing the progression of atherosclerosis. The difficulty comes not only on the physician side, also on the adherent side. Whatever recommendation we give it to the patient, there are many factors which influence the patient's behavior. So patients may not take it. And we are today living in an era of a very high influence of social media. People give a larger weightage to social media compared to an expert medical advice. So let's move on to the decoding of clinical inertia. I am going to highlight very quickly certain findings for two research publications from India. This is one paper, Dr. Borgarkar. This has been conducted by Sun Pharma medical team into lipid map kind of a study. Is not something, but still a survey. Whatever it says, whatever data captured, if you look at 2,200 doctors, different clinics covering close to 16,000 patients, and you see the bar diagram, achieved LDL goal and did not achieve LDL goal in 3 different categories of risk and different level of LDL. On the right two with 2 risk factor or presence of ASCVD, you will find that large majority, close to 80%, do not achieve an LDL target. So this was concluded 79% received moderate intensity statin for primary and secondary prevention when they actually required high intensity statin. The group, none of the patient achieved LDL of less than 70, which was required as per the guidelines. Another study called Diverse study, which looked at 3,000 patients, 483 sites. This paper was published 7 years back in API journal. And this showed that only 7% of the patients achieved LDL less than 70 milligram. And there were 18% between 70 to 100. So more than 25% of the patients all had LDL level higher than 100 milligram. This is kind of a real scenario in Indian practice, in spite of statin being present for so many years. So let's take this couple of papers and physician behavior, presuming that physician is partly responsible element. We would come to the patient factor a little later. These are all the risk calculator which have evolved over a period of time. Q-risk score is another one which is very, very close to capturing multiple data in Indian patients. Another team in ARIS is propagating and doing extensive work in the field of CV risk measurement. So Dr. Dargad, you are there. I have a question for you, that why doctors underestimate the risk of cardiovascular disease? Most people do not have kind of a CV risk assessment.
Thank you, Sanjeev. We have been knowing the effect of the statin and the lipids for a long time, along with all other risk factors commonly. But I think various scores have been made mainly for the Western country. None of them were very typical of Indian, because we have a much younger age group, the difficult type of HDL lowering, triglyceride high. These all the factors were not taken into the consideration. None of these scores were very popular in India, though we are using Framingham and USA QRS risk and all that thing. But of course, it's not easy, also not very difficult now with the apps actually. But I think the basically majority of these scores, I think what ARIS is doing now is a good thing, something which will come out to Indian standards actually, which will love to have a much earlier data and much better way of presenting it actually. So we'll have more better guidelines now later on. So so that will be better. But present scores among, I think, Framingham is much more probable and much more older, which are available, and the multiple other scores. The practically, which we all know, as you said, the inertia from our part, but even we know the statins are available, and there was a patient, at least the HDL should come down below 55 as per the new guidelines, or 70. Many of the people don't achieve. We had the 7% was the data a few years back, and now also it's not very good data. In spite of knowing all the benefits of the statin, and I think one thing which have brought down the mortality in the Western country is the statin reduced LDL. Only other one factor which might come to the smoking cessation, if can achieve it, actually is difficult. Maybe the other beneficial effect to that extent. Hypertension, diabetes has been there, obesity, but I think the one of statins is a very easy tool. And now with the cost-effective drug available to us, still is not used. Among the, I think the scores, it should be something very simple and Indian standard, I think will come, which will be more and more popular to us.
Thank you, Dr. Darkad. I would not be sharing today, but Aries has recently in last 2 months collected CV risk of 12,000 doctors in clinical practice, physicians, and you will be shocked to find a significant number of people, doctors have high CV risk. The data would be made public in couple of months, but that is how the scenario is. If we shift the scenario in a diabetes clinic, 10% of our population is diabetic, 10% is pre-diabetic, and a huge number of practitioners now take up diabetology as their practice. So we have a senior consultant, Dr. A.K. Das, who will tell us why there is more CV risk in diabetic people who are at higher risk within diabetic population. Dr. Das, please. You are on mute. Ashok, you are mute.
Sanjeev, this is a very focused and very pointed question and very important question. First of all, I will try to recite the findings of Dr. N. Sattar, which is published. And this Dr. N. Sattar from UK have shown very, very important finding. He has said that 10 years of diabetes is equivalent to a cardiovascular risk. We also know from the myriads of papers published earlier, people used to say that even diagnosis of diabetes is equivalent to 1 MI. As if you had 1 MI, Professor Govindan is here, he will agree with that. We also had in 2004, when Sanjeev, AHS said that the diabetes is a cardiovascular disease. Be that as it may, let us explore the reasons why it is so. To my mind, there are 5 reasons which is very important. Number 1, in Indian patients, diabetes starts very early, type 2 diabetes. Therefore, the quantum, as you rightly, beautifully showed, Sanjeev, the quantum exposure of the lipids, of the other things, like I'll cite 3 things: uncontrolled hyperglycemia, uncontrolled dyslipidemia, and uncontrolled hypertension. Out of that, I'll rate uncontrolled dyslipidemia very high, because people tend to ignore it. Now, coming back to the question that you have asked, the quantum of exposure to this is high because it is, as you rightly showed, the numbers into the years they're exposed, number 1. Number 2, it has been also shown that the diabetics also have a perfect recipe of the comorbidities. In the recently published, as you rightly said, I chair the ICMR in-depth study. We recently published on the 7th of June 2023, the comorbidities of diabetes. And we showed, believe me, Sanjeev, that 82% of diabetics in our country have at least one dyslipidemia, one facet dyslipidemia, either HDL lower or TG high or LDL high. And out of these 3, LDL high is more widely prevalent. Number 2, we also found that the hypertension in normal population, non-diabetic population, is about 19%. But in diabetics, it almost touches 47 to 48%. And the third important thing, obesity, including visceral obesity, is almost 66%. And suffices to mention about sedentary lifestyle and even no leisure activity of sports and walking activity. So that's why I believe that our country people, type 2 diabetics, are more prone to severe risk. And when they get the severe disease, Govindan agree with me, this is more severe. They fare worse in the ICU, intermittent care, or when transferred to ward. Even after discharge, the heart failure is more, and they fare worse than non-diabetics.
Dr. Das, would you like to comment that what percentage of diabetics could have subclinical atherosclerosis,
I think that's a very important question.
as well as the microalbuminuria as a risk factor?
Yes. I think, microalbuminuria is a marker of endothelial dysfunction. And from the time of Margon, it has been equated to the malignant cardiovascular marker. Why it is malignant cardiovascular marker? Because the microalbuminuria indicates endothelial dysfunction. And the microalbuminuria is very widely prevalent in the diabetics. In one study that was done by Mogensen in the Denmark, it was shown to be close to 50% who had microalbuminuria. And this microalbuminuria is an indicator of malignant angiopathy. You rightly said this malignant angiopathy is subclinical. They do not appear, but they have malignant angiopathy. And the plex can rupture anytime, and they can get a sudden cardiac attack. Beyond this microalbuminuria, Sanjeev, there are other elements which also contribute to subclinical atherosclerosis, because the sugar, triglyceride being, we have in India, you asked me the question, why Indians? We have this atherogenic dyslipidemia, which yourself have written many times. High TG, high LDL, low HDL. So therefore, it has been rightly said, low HDL is a marker of diabetes, and low HDL is a marker of the subclinical atherosclerosis, as also LDL being high.
Thank you, Dr. Das. So let's take another example. In one of the trial, an extra dosage of a statin reduced LDL by further 20 milligram. So when high intensity is used compared to less intensive statin, 15% further reduction in vascular events were observed. Death and non-fatal MI reduced by 13%, coronary revascularization by 19%, and a stroke by 16%. So additional intensity reduced events further compared to low intensity. So I have a question for Dr. Govindan, as highlighted by other two experts, that more intensive control is necessary. Most physicians get happy with 30% lowering and so some kind of 100 milligram LDL as a target. So would you describe what would benefit more, 30% versus 50%? Low, moderate versus high intensity. Dr.
Okay. Yeah, thank you very much for that question. First of all, what we have to understand is that why are we reducing LDL? LDL, unlike even diabetes and hypertension, are silent, but cholesterol dyslipidemia is even more a silent killer. So why you want to reduce LDL is only to reduce events, coronary artery disease, stroke, peripheral arterial disease, whatever it is. So that means the percentage of LDL reduction depends on the risk of the gentleman developing coronary artery disease. If you go into the fundamental pathology of why atherosclerosis occurs, it is because LDL cholesterol enters the subendothelial level. Now, this can happen in two situations. One, when the LDL is high. Obviously, when there is no more LDL, it will go under the endothelium and form a nidus for atherosclerosis. But this can also happen when the endothelium is porous or dysfunctional. So when there is endothelial dysfunction, like in a diabetes, we have already seen, or maybe in a smoker, or maybe in an obese person, you require an even lower LDL cholesterol. That is why it is said now that the reduction in LDL cholesterol will depend not on your baseline LDL level, but on your endothelial function, which in turn depends upon the risk of coronary artery disease, the risk of atherosclerosis. Now, we have to understand that this 30 to 49% LDL reduction is known as moderate intensity statin therapy, and that is produced by 10 milligram or 20 milligram of atorvastatin or 5 milligram or 10 milligram of rosuvastatin. Whereas more than 50% reduction is called is attained by high intensity statin therapy, which is 40 to 80 milligram of athrostatin or 20 to 40 milligram of rosuvastatin. Now, low intensity statin therapy, which produces less than 30% reduction, presently has hardly any indication. Maybe in patient who cannot tolerate a high intensity statin, you can give a lower dose. Otherwise, there is no role whatsoever for a low intensity statin. So how do you choose whether you give high intensity statin therapy or moderate intensity? For that, you have to divide patients into the risk, as I said, very high risk, moderate risk, and low risk patients. Now, of course, the risk factor, suppose a patient with very high risk includes patient who already had an event, which can be a clinical event like a myocardial infarction, or maybe an imaging event like you do a coronary CT and find that there is a plaque in the coronary arteries. They are all very high risk because they have already proven that their endothelium is bad or the endothelium is porous. Similarly, patients with a family history, familial hyperlipidemia, kidney diseases again with an eGFR less than 30. And of course, we have already heard of diabetes with target organ damage, with major risk factors. They all need a reduction of more than 50%, which means they all require high intensity statin therapy. A word here, remember that it is not 50% reduction alone. The value should be less than 55, which means if the baseline LDL is say 120, you reduce by 50%, you reach only 60, but what you require is less than 55. So you require maybe more than 50%. You have to add maybe ezetimibe in that situation. The high-risk individuals are little less high risk, which means they may be having a single elevated risk factor, maybe an LDL of more than 190, or a BP of more than 180 or 110, or maybe diabetes without any target organ damage, without any risk factors. These people require 30 to 50% reduction in statin, which means they require moderate intensity statin therapy. But again, remember here, they require more than 50% reduction plus an LDL of less than 70, which means if their LDL is 140, for example, 150, for example, you give high intensity statin therapy, it falls down to 75 and you require less than 70. So high intensity statin therapy for both high risk and very high risk individuals. The difference is that in high risk individuals, you require an LDL of less than 70 in addition to 50% reduction. Whereas in a very high risk individual, you require a reduction of more than 50% plus an LDL of less than 55. So these are both people who require high intensity statin therapy. Now, what about moderate intensity statin therapy? These are patients with moderate risk, like say a young 40-year-old diabetic with no other risk factors, no target organ damage, recently detected, which is not a very common person, or maybe an elderly person with no other risk factors. These patients will require a moderate intensity statin therapy, which means you give moderate intensity statin at 30 to 59% reduction, 30 to 69% reduction, 49% reduction. Now, remember, what is important is the baseline LDL level, the reduction from the baseline LDL. Like theoretically, it is very unlikely to happen. Theoretically, for example, if you have a patient with an LDL of 50 milligram and he develops an acute myocardial infarction, that means this 50 milligram is toxic to his vessels. And so you require a 50% reduction. So to sum up, what I would say is that in people who are very high risk or high risk, forget about the baseline statin. You don't have to look at the baseline statin. Start them on high intensity statin. Similarly, people who are on moderate or low risk individuals, start them on moderate intensity statin therapy. Low intensity statin therapy in the present day have hardly any. But again, in the high risk and very high risk, also remember that the absolute value of 70 and 55 are also important. I hope I am clear.
Yeah, thank you, Dr. Govindan. Just a short answer. In reducing the MI and CV risk, what is more important? People are getting glucocentric, trying to reduce A1C, while LDL gets neglected. So what do you think, LDL versus A1C, both are to be reduced?
Yeah,
One
both have to be
easy.
reduced. Yeah, both has to be reduced. But intensive blood sugar, many people mistake all these trials, intensive blood sugar control is probably not required. I will not say blood sugar control is not required. I will say intensive blood sugar control, where the patient goes into recurrent hypoglycemia, is dangerous in a patient with coronary artery disease. Whereas lipid lowering and LDL of 25, for example, in the Fourier trial with PCSK9 inhibitor, did not create any problem at all. So drop down the cholesterol level, whereas HbA1c, maybe you can keep it around 7, 7.1. Don't bring, if my patient has an HbA1c of 6.5, I will definitely be worried. I hope Dr.
Thank you.
Das agrees with me.
Thank
Yeah,
you,
I
Dr.
think-
Govindan. We'll take up this point again.
Sanjeev, can I come back to it 1 minute? I think
No, we will come back to the same topic again. So I want to show them a PALM registry. This is 5,700 patients which surveys were carried out, and they asked 3 questions about statin experience, reason for declining, or reason for discontinuing the statin. And the findings were very important. Many patients believed that these are addicting, habit-forming drugs, or they want to try something natural and probably want to try diet and exercise, which can hardly get us to the target or a goal. So these are the reasons reported for declining statin therapy. If we start from the top, we can see worry about the side effects, try diet, exercise. People feel that I don't need a statin. I don't like taking medication, prefer natural remedies, cost reason. All these are in the mind of a patient and does not want to take, which is irrespective of primary prevention or secondary prevention. These are the people who decided to discontinue the statin. So probably 50% thought that they experienced side effects. When LDL was normalized, no longer needed, and the similar reasons again for not taking. So let's take these issues in the mind of a patient one by one. And Dr. Dargad, what about the seriousness of a condition? As Dr. Govindan highlighted, that dyslipidemia is a very, very silent condition. In a different paper, I have read that patients reported that doctor never explained to us the importance of a statin. Dr. Dargad, would you like to comment on these 2 issues about how do we go about, what would you advise the listeners, physicians to handle this situation?
Thank you, Sanjeev. I think one of the reasons why people don't take statin, you said one of the reasons being the physicians themselves were responsible for it. We don't explain this because it's being a silent, so that the statin at a lipids at the higher level don't cause symptoms immediately, maybe cause after 10 years, 15 years, 5 years, depending on it actually. So people never think like hypertension. So hypertension at least have some symptoms. Sugar will have some symptom, but dyslipidemia remains silent as a symptomatically. And as you said, the time to explain the need and importance, nowadays at least we are taking some time to spend the pain. But as you say, the various reasons given, excuses for the patient, I want to try diet and exercise, which is usually said not going to much help. I don't become addiction as one of the reasons. I want to talk the natural, some other alternative medications, other thing. That people think that the cost and insurance, I think, is not a big issue now at least, Sanju, because I think the cost has come down, and I think Eris has done very good thing. 10, 20, 40, they are actually coming at the same cost. So I think that issue of intensive therapy not being explored because of the cost does not so. Side effects profile, I think we do agree, everybody. There are some side effects like cramps and other things to people. So we do have appreciate help that ezetimibe, something has come to at least to reach the target, those side effects, and at least we can try to give vitamin D and correct their thyroid if they have, or give other things actually to the side effects wise. I think one molecule, pitavastatin, at least in moderate intensity, has the least side effects as the side effects of cramps and other thing. The other side effects, many times people come to literature read that these drugs do cause diabetes new onset. I think this is actually, though fact, we agree. The incidence is so low and the benefits are so intense, we have to explain them, because very well-read people do come and ask me, as we're going to this drug, I'm using it longer time, do I'm going to get a diabetes? I think some of the pre-diabetes might convert. And what are the ways to prevent it? I think the good exercise, I think ARBs, and when we try this and all, we tried, and some data came with hydroxychloroquine. But I think this is one of the facts we have to explain to patient, the side effect part and the cramps. But the side effects have never been a major challenge. This is the inertia on the top of the physician and the patient having getting various advices from the other friends, colleagues, and the other thing, and alternative things, trying the diet, exercise, all these things, I think are the reasons for not going to the intensive therapy patient who need it actually quietly, and we can definitely bring down the cardiovascular burden of the medical hall to the India, at least a country like which have a high risk, and with the cost of these revascularization is so high in our country, I think we should incite them to, at least if you don't do it, you may have to go for a revascularization, which is quite an expensive and maybe a repetitive procedure. So I think some time we have to give. We may have to have a health educator like diabetic educator to explain the patient about the importance of the statin and the lipids. I think something we should come a dietitian, and I think if the physician don't have time, at least they can explain about the side effects of the part. Thank you.
Dr. Ramesh, we need to explain what statin will do, what statin will achieve, because we don't explain. People go on a Google and they first get the wrong answer instead of a right answer. They'll end up with all the other therapies which will normalize LDL, but they would not read the statin. So let's take two more questions on the same subject. For Dr. Das, I have a question. As Ramesh has highlighted, 10, 20, 40 and ezetimibe all cost the same in Eris Krivas brand, but other brands are expensive. What do you think as a diabetologist? Patient has a huge list of anti-diabetic neuropathy drugs, 2-3 antihypertensive. So do you think pill burden is an issue, or we succumb to patient who refuses that, no, doctor, I will try, don't give me statin today? So patient preference. In your experience, how do you handle these two issues?
I think it is very important to remember a diabetic has multi-comorbidities. But what is most important, as we just now discussed, is hyperglycemia, hypertension, and dyslipidemia. And the pill burden is not the only thing that the patient should be concerned about. We know for certainty today that the statins have brought down the cardiovascular attacks and the death by 33 and 19%. You also saw similar data. And it has been also in a lighter vein, anything good in the tablets is compared to statins. Today we call the empagliflozin, dapagliflozin, canagliflozin, other drugs, we say the second statin. What does it mean? It means the statins are indispensable. As rightly Govind pointed out, we have a HbA1c K paradox. When you bring down the HbA1c, the weight goes up. That might also result in other types of fat. However, in today's parlance, it is very important that one should bring down the statin as per the dictation given by the various guidelines which we'll discuss. The question you have asked is, what are the importance of these high dose statins? I must tell you, the pill burden can be reduced, Sanjeev, by combining anti-diabetics, by combining antihypertensives. And the statins have to be on the roll. Any chronic disease, if you stop the treatment, it goes up. And that is very true for the statins. So we will impress on the patient, they should not stop statin by any means. Third important point, the most important thing is the misinformation. People give misinformation that too many tablets, addiction forming, and Google doctors, and also the hearsay and misinformation by the other people who call us alternate system, so-called quacks. That has to be laid to rest. Statins are necessary. There are many diseases treatment not available. Here are the diseases where treatment available in the form of pills. They must be taken. What is the most important thing when drugs do not work? When you don't take it. I tell to my patients, you have to take it to get the result. And also, last thing I'll point out to you, that you also raised the cost, and also Govind raised, and also Ramesh raised. I must tell you, we wrote an article saying that treating diabetes and dyslipidemia adequately and properly is cheaper. Not cheap, not treating properly with proper doses. To give a homeopathic dose of 2.5 milligram, 5 milligram does not serve the purpose. Treating appropriately, adequately is cheaper than not treating appropriately.
Thank you,
Maybe one
Doctor.
point actually, the pill burden, we India at least have antiplatelets most of the time combined with the higher strength of the statin now available, 40 milligram rosuvastatin or 40 milligram atorvastatin, can definitely most of these people secondary patient will be on some antiplatelet.
So
And
antiplatelets can be combined more easily.
combined very easily, and it reduces the cost because most antiplatelets are under drug control prices. So actually, the price comes down very heavily, and now even 40 milligram is available with the combination previously then.
I
So
think
that is a
Sanjeev,
pill burden we can reduce.
what Ramesh said is very important. We have popularized the term CCC. When you give a fixed drug combination that you both were referring to, it is compliance is better, the cost is less, it is more convenient.
Thank you, Dr. Das. So we take up another question and an important issue by Dr. Govindan. Patients and many physicians believe that side effect incidence is very high, but multiple recent data, meta-analysis, epidemiological said something different. So perceived side effect versus actual side effect due to statin. We have had a dedicated session in the past on SAMS, 1 hour session on statin associated muscle symptom, but you will still summarize. There are many who may be new today. Dr. Govindan, please.
Yeah, thank you. If you look at the side effects of statin, maybe you are divided into two groups. One is those side effects which you see in trials. In trials, you know, the patients are followed up by doctors. So the side effects are objective. You know that this person has a side effect. The other group of side effects are seen in registries. They are observational registries. So it is more what the person perceives as a side effect of statin, which is fueled, as has already been said, by Google, by WhatsApp, universities, and not really scientific. Now, if you look at the side effects of statin, of course, the most clinically relevant is myopathy. And if you go to the extreme, myopathy can go into rhabdomyolysis, is the most severe form, characterized by severe muscle pain, muscle necrosis, myoglobinuria, renal failure, and even death. But the frequency is very, very low, 1 to 3 cases per 100,000 patient years. So in your life, you may hardly see one case. And even that is when you combine statin with other drugs like, say, fibric acid derivative. So that is very, very, very less. But if you look at the observation registries, as already said, the most frequent reported is the SAMS or statin-associated muscle symptoms, where the patient has some muscle pain, some muscle tenderness, but CK is normal, the enzymes are normal, there is no major functional loss. And this is about 10 to 15% among statin-treated individuals. Now, I think one has to differentiate between statin-treated individuals. If the patient had a recent MI, for example, patients do not report this SAMS in 10 to 15% because they know that they have to take statin even if there is some muscle pain. But if you look at patients in a primary prophylaxis group, the frequency of SAM may be even more than 15%. I'm sure all of us have seen patients who had SAMS, statin-associated muscle symptoms, stopped statins, comes with an MI, you put them on high-dose statin and nothing happens. No more SAMS. So they are all possibly what is known as the nocebo effect. That is one caused by the negative expectations, which, as we know, comes from Google and various WhatsApp forwards. The second maybe is the liver is the next culprit, the SGOT and SGPT. Normally it occurs in statin treatment, mild elevation, 0.5 to 2%, especially with high dose statin. But in general, one has to consider that you don't have to worry about ALT elevation unless it is 3 times the upper limit of normal. So if the upper limit of normal is 40, you don't have to worry till it is above 120 on 2 consecutive occasions. So that is very important. Whereas mild elevation of ALT 60, 70 is not associated with true hepatotoxicity, does not lead to any progression in the liver failure, with the result that most guidelines now do not recommend routine monitoring of ALT. So there is no need to measure ALT in patient on statins. In fact, it will have the opposite effect. Because if you measure the ALT and it comes as 41 or 42, there are many patients who will immediately stop statin, saying that they are going to develop liver failure. So liver dysfunction, ALT elevation is purely benign and you don't have to worry that at all. Well, one true real serious side effect is increase in the new onset of diabetes. There is no doubt about that. It is consistent. It is dose related. The number needed to cause one diabetes is about 2.5 over a 4-year statin treatment. But even in those patients who become diabetes, the benefits with statin are much, much more than the risk of a new onset diabetes. So risk is definitely there with statins, and it is more with more potent doses, more potent statins, and at a higher doses, and is also higher in the elderly. But that should not prevent us from writing statins in patients who require them, because the benefits any day overtake the small increase in diabetes benefits. The absolute reduction in the risk of CVD in high-risk patients clearly, without doubt, outweighs the possible adverse effects of a small increase in the incidence of diabetes. In the earlier days when statin came, another supposed or perceived side effect was the increased risk of hemorrhagic stroke, because some of the trials showed that there was an increased risk of hemorrhagic stroke in patients who were on high-dose statin therapy. But subsequent studies showed conflicting findings. And right now, nobody accepts that high-dose statin produces hemorrhagic stroke. In fact, even in patients with hemorrhagic stroke, statins are indicated because a hemorrhagic stroke also suggests vascular disease, not just thrombosis. Even hemorrhage suggests that there is a vascular disease, there is atherosclerosis. And so these patients also require statin. So I think if you look at the general population, the most important side effect is muscle symptoms, which is more often perceived than not perceived. So one thing we can do is to get an enzyme done and then tell the patient, see, the enzymes are normal. So maybe you are overestimating the pain. The pain may be because you have started walking now, and that may be the reason for the pain, and that will go off if you continue your walking. So maybe a little pep talk with the patient will make sure that the patient takes statin. And I said it is all the more in primary prophylaxis, but because the patient does not perceive the event that going to happen if he does not take a statin, whereas he perceives the muscle pain, he perceives the slight increase in ALT, etc., etc. So a good session with the patient will probably help.
Thank you, Dr. Govindan. And listener doctor, if anyone interested in systematic workup of truly a myopathy or a muscle involvement, we have had a session on importance of CPK estimation and how to go about. Medical department of ARIS would be happy to share articles in relation to role of CPK in a highly suspected patient. To going further, let's see, and the third topic today is the guidelines, that why guidelines are made and why guidelines are not followed. So the first point, this was an interesting paper in 23 last year. The good, the bad, and the ugly part of a guideline. In general, whatever is the subject, whatever is the treatment part. So there are some of the issues we will take up. Dr. Dargad, what do you think? Physicians read the guideline or not? Number two, whether the guidelines are written in a way that they can understand the guideline. Many practitioners in our country, huge country, everybody practices or supposed to practice a statin and dyslipidemia, whether it can make out. And the suspicion in relation to relationship between pharmaceutical industry and physician in practice. Dr. Ramesh.
Thank you, Sanjeev. I think guidelines have been made for the benefit of the physician, but they are being made by the people in a very monotonous way. I think they're not a very attractive way to interact with people and we become practical. So though we have been following a lot of guidelines today, like as you say, the LDL has to be brought down below 55, everybody understands, but practically there are some difficulties. But what should be done to improve this, actually the compliance of the patient, the physicians actually overall, the importance, of course, as you said, the pharma and nexus may be existing at a very high level, but I think all these have been evidence-based medicine, and we should accept that these guidelines have shown some benefit, and we all should follow it. But I think we always not going very seriously about the guidelines. We do feel be happy that the LDLs come down certain extent, or the blood pressure has come down to certain level, or HbA1c has come to, but we were not happy with exactly the level what we want to achieve. It's very, very difficult actually. That is the Many times patient has to be convinced that you're 55 LDL. No, the lab has written it 100 as a normal debit. Why should I come to 55? So many of the labs still have a stationary which is very old. Even 130 is written as a normal for many people. So that gets confuses the patient. The guidelines are very useful. We all should follow. But I think they should be made more practical, more attractive, and the country to country wise relation. It should be, we should have our own guidelines with lot of, I think, the API and has been doing a lot of things to improve our own guidelines. Like LI has come now, Lipid Association India has come down. Even 55, some people have come to 40 below LDL for Indian setup. The age group has been changed. Even the blood pressure guidelines for us has changed. All this has been done, a lot of things. And I think we have seen some of the articles which have been coming up and improving our guidelines. But I think still we are far away from the real guideline associated things exactly coming. And some of the other negative point of, I think, some people have gone to a very low LDL also, something below 20 also. Very intervention cardiology where fear of the stent thrombosis has been very aggressively, people with on PCKS inhibitor, high dose statin, ezetimibe, everything, that also has some negative side which has to be explained to them. I think there is one paper which has shown that the renal complications higher when this LDL goes below 20 or 10 actually. And even then they continue to have a PCKS inhibitor, Raptara and statin. I think that also should be explained in the guidelines. The very low is not required. What we require is 55 or 40 at that level is helpful, even secondary prevention or high risk group or very younger people. In the guidelines, many of the things, I think, Sanjeev, we are forgetting the lipoprotein A has no guidelines and no treatment available to us, which is a very, very important common risk factor for the Indian subset. Actually, we have been now seeing a lot of association with the LPA, with the cardiovascular mortality, and we don't have exactly what is 30 was taken to be the guideline below LPA, and we don't have a very good drugs, which are PCK is not a reality for India, which many people will not be, even though deserving, may not be able to afford it. Even I think the newer PCKs has come also is more than 2 lakhs actually. So I think we need even the guidelines for these LPA, triglyceride, HDL, all these things actually we need to improve these certain things actually. And I think rising HDL also, there are hardly any drugs available. As I was talking about pitavastatin, my favorite drug, which is the one drug which improves HDL to some extent. So I think what is the thing, this LPA is especially for Indian scenario is very, very important. I think we should have a guideline, but I think the guidelines are ideal. We should all follow, try, but still I think there is quite a lot of inertia in following the guidelines. Thank you.
But Dr. Ramesh, it really covers up the evidence-based papers, which so many papers an average physician would not be able to read.
Go to that level to achieve.
Yeah. So let's take one more question that for Dr. Ashok Das, who had been part of many guideline committees, especially in diabetology. So advances in medical, biomedical, health services have reduced the level of uncertainty in clinical practice. This comes from an Institute of Medicine Committee on Standard of Developing Trustworthy Guidelines. Do we need, can we trust or not? So what do you say, Ashok?
I think it's a very important question. My approach will be threefold. Number one, guidelines are essential, but as you rightly pointed out, they have to be neutral, they have to be practical. At the same time, they must have a consensus. Without consensus, from one side developing guideline favoring X, Y, Z is not a guideline at all. Therefore, Sanjeev, they are very important for the treatment. Number two, guidelines are a railway timetable. We are treating LDL. If the guideline says it must be 50 or 55, we know how much we are away from the guideline, like how much the train is running late today, how much time we're left. That gives a thing. The most important thing that the medical field is changing very rapidly. As Ramesh and me are together in the same tribe. We're in many conferences. But to catch the changes is not easy. They have said that the medical science advances in every 36 days, new things come, which are very practical. Guidelines, when they're updated, they catch them all and put them in a very succinct form. There is one more use, Sanjeev, which I have realized, that is the legal protection. Ramesh, am I correct? Uni, am I correct? If we have guidelines which has given something, and we have stuck to the guideline in our management, we have a legal protection. Dear Sanjeev, I must tell you that you told beautiful thing in the beginning. Earlier, clearly more, and also lesser are the objective of LDL therapy. I cannot agree more. I must tell you that today people say, and you know it, that the first year treatment matters. Now it has come to guideline. And you get my point, Sanjeev? It was not there before. Today guidelines say early aggressive or early intensive control matters. Therefore, if Ramesh, me and Uni are giving treatment to control LDL early, more and more intensively from the very beginning, that Chicago School of Medicine's finding that in 30,000 patients, it produced great benefit by early aggressive, early intensive control, it becomes the order of the day. So dear Sanjeev, I feel guidelines are most welcome, but they have to be neutral. They have to be, you rightly said, Sanjeev, EBM, evidence-based. They have to be practical. They have to be consensus. Every guideline that I make or I am sharing over, it goes to 700 people in the country to give their inputs. Everybody does not give the inputs, but at least 50% give their inputs. Thank you, Sanjeev.
So there are various confusing papers in the literature called a position statement, expert committee recommendation, and the practice guidelines. But more or less, more people are involved. It's very, very clear in relation to atherosclerosis that LDL is unequivocally causes ASCVD. Huge number of participants, 20 million person years follow-up, 150,000 cardiovascular event. Everything says the same. LDL is a major, major culprit. So I'm sure cardiology is a highly elite, well-read community, and multiple drugs-related guidelines are written: heart failure, 2 drugs, post-SCAs, and intervention. This kind of evidence for every single statin trial, these evidences have been generated. So Dr. Govindan, what do you say about guidelines on statin particularly?
Now, as you said, there are multiple guidelines. There are guidelines from the USA, there are guidelines from Europe, you have Canadian guidelines, Australian guidelines, you have Indian guidelines also. The Lipid Association of India has brought out guidelines. But if you go through these guidelines, there is not much difference except maybe for some values. Some are very aggressive, some are less aggressive, but all are aggressive. Because we know that LDL aggressive reduction is good for the patient. So my advice to physicians will be, it is okay, you can follow whatever guidelines you want, but what is most important is that you make sure that you reach the targets. Because even though we can blame the patient that he has some perceived side effect and is shocked, or he thinks that he can get it down by yoga and meditation, basically it is our fault. Basically, it is because we have not spent time with the patient. We have not talked to the patient. So I would put physical inertia as probably the most important. And that can be countered if the physician has a confidence that the guidelines are good. Unless you are confident about something, you cannot make another person confident about it. So if you yourself are doubtful about the benefits of high-dose statin, you are in no way going to convince the patient that a high-dose statin is important. So I would suggest that all of you should read some guideline, whatever it is, and get convinced that high-intensity or moderate-intensity statin therapy is good for preventing cardiovascular disease, which if you take the last 100 years, except for 2 years, 1917 and 2020, all the other years, cardiovascular disease was the important cause of death across the world. These 2 years were, one was Spanish flu and the other was corona. Otherwise, all the 98 years, the commonest cause of death was vascular diseases. So it is important that we aggressively treat it. And for that, I think you should go to the guidelines and convince yourself these guidelines are good. Especially because, as I already said, the patient have no symptoms for dyslipidemia. And again, as Dr. Ramesh said, if you go by the laboratory value, there are laboratories we still say LDL normal, less than 130. So these are all things which will change the patient's consent. The patient will believe more in the laboratory value, and he will say, see, the value says it is 130 is good. So I would say the best option actually would be to start the maximum dose, high intensity or moderate, unlike diabetes or hypertension, where you start with a small dose and gradually increase the dose. This is one situation as per guidelines and as practice also says, that you start with a high dose so that you bring it down to low levels and then you don't reduce the dose unless, as Dr. Ramesh said, if the LDL is 20 or something like that, which is very, very unusual, unless you give a PCSK9. This is all the more true in primary prophylaxis, where the patient is still skeptical about the benefits. And in secondary prophylaxis, as the time from the event increases, first year after the MI, most patients would be willing to take high dose statin. By second year, they have already become skeptical. By third year, half of them have already stopped the statins. And by fourth year, only 25% are on statins. Remember, the only medication with strong data on prophylaxis is statins. Even antiplatelets, aspirin, for example, have no data in primary prophylaxis now. In primary prophylaxis, the only medicine useful is statin. And as we have seen, it is very safe with hardly any serious side effects. Similarly, with diabetes, this is another area where I am sorry to say even diabetologists give, as Dr. Das said, 5 milligram alternate days of athrostatin, which is absolutely useless. All diabetic patients above the 40 years need statin. Maybe moderate intensity, maybe high intensity, but they need statin irrespective of their lipid levels. So my advice is to read the guidelines, convince yourself of the necessity for aggressive control of diabetes. Don't go by lab values. This is one treatment where there is strong data, and it is whether it is primary or secondary doesn't matter. And remember, let me tell you, it is your duty to convince the patient that this has to be continued. You cannot just say that I have convinced the patient, but the patient, unfortunately, is more interested in lifestyle. Lifestyle modification is good, not that it is not good. But I think it is our duty to convince the patient of the benefits of this drug. And for that, we have to be convinced about the benefit. And for that, we need guidelines.
Thank you, Dr. Govindan. Only in lipid guideline, there is no inconsistency between different country and different bodies. They are highly consistent. So let's see that why it does not get followed.
Sanjeev, one thing, is the nexus between the pharma and the guideline, how much you do think is a real fact or is there something just theoretical what you think? Because in JNC 7 guidelines given thiazide is the first line drug and with subsequent year it changed immediately.
Correct. Guidelines also
nexus of pharma with
keep
guidelines.
changing in diabetes as well as hypertension, but probably in lipidology, there had been so far no alternative option, and it's not in the near future. So this is gaps and disparities in primary prevention. Dr. Ramesh, most physicians and diabetologists practice in an era of, in most patients, a primary prevention, which is taken very, very lightly or not believed. It was lowest in a people with just 5 and 7.5% CV risk category. So any suggestion to practitioners on how to improve statinization in primary prevention?
We have to explain them the risk of the revascularization, the cardiovascular death, stroke, other thing. I think that it will be and the data which is shown very clearly the prevention in that primary prevention. And then I think we'll have to convince them. Actually. Primary always is difficult. I think secondary people agree very well.
Yeah, secondary is more easy. They have suffered. Once they have gone into ICU, they know that their heart is at risk. So this is now, Ramesh, this is a paper which talks about patients who already had an atherosclerotic vascular disease. In the midline, this point is an index event which has happened. And there is a 12 months follow-up after an index event. So this is very, very interesting finding. As you see, 48% were adherent to statin, 51% were non-adherent after the index event. So even in secondary prevention, this is what happens. Age-wise distribution is also written about moderate and high intensity. So picture is not that easy as it appears. People are very obedient for probably first year after stent. And then this is how it looks like. Dr. Govindan would explain. I would not go into the details as you can read the reasons. Dr. Govindan, please.
Yeah, I think the picture speaks for itself. As you said very rightly, primary prevention is actually, one would presume that primary prophylaxis is more difficult because it is more difficult to convince the patient. But in secondary prevention, once the patient, as you already said, has an event, the patient will be definitely frightened. And so probably he will take the drug for the further away you are from the event, the more likely that the patient is likely to be on statin. But here, one thing, unlike primary prevention, where you can divide the patient into low risk, moderate risk, high risk, or very high risk, here there is no classification. All secondary prevention patients are high risk. And remember, secondary prevention is not just myocardial infarction. Secondary prevention is coronary artery disease, stable angina, unstable angina, stroke, peripheral arterial disease, abdominal or aortic aneurysms, and even nowadays, imaging evidence of atherosclerosis. If you do a coronary CT and find a plaque there, or if you do a carotid Doppler and find a plaque there, these are also secondary prevention. All these, remember, are very high risk patients, no doubt about that, and they require high intensity statin therapy. So how can you make sure these patients will be on high intensity statin therapy? I think first thing is start with high intensity. Don't start with a low dose and go up. Start with a high dose statin, irrespective of the baseline levels. And if the target is not attained, well, you can add other drugs like ezetimibe, PCSK9 inhibitor. There is a lot of data, strong data, but very costly. Let us wait for it to be off patent. Then I'm sure the Indian pharma companies will definitely bring it out at a lower cost. So if the patient can afford, don't hesitate to start a PCSK9. In patients who are intolerant to statins, go for a bempedoic acid. But I would like to again reaffirm that all secondary prevention patients, all patients with documented atherosclerosis are very high risk patients and they require high intensity statin therapy. And if they, in spite of high intensity statin therapy, develop an event, that is the situation where you would probably aim for an LDL of 40 or 30. Because here, on spite of high dose statin, they again develop events. But as I agree that the problem becomes more and more difficult as you go away from the event. 2, 3 years, 4 days down the lane, many patients would have gone to 5 milligram athrostatin till they get another event. That is unfortunately the story.
Thank you, Dr. Govindan. I was surprised that 30% even did not receive a statin. Provider decision based on information. So there are all kind of practitioners everywhere. So Dr. Das, for you, as what highlighted by Ramesh earlier, complexity of guideline, lack of training in CVD prevention and time constraint. These were the reason put up by some of the experts in JACC paper. So this is how also in a JAMA paper, very interesting highlight, you can see lack of awareness, lack of familiarity, lack of agreement, self-efficacy, inertia of previous practice, what they have learned in the past. So these are kind of a barriers. What do you think? It is going to be, here you can see awareness, familiarity, percentage is written. Probably this is going to be the last question for you.
I think Sanjeev, this is a very important question you have asked. I will give an example which may be little too strong example. You know, one of the American president died of tuberculosis, and that time anti-TB drugs were not available. But another American president died, Eisenhower, when the patient, the anti-hypertensive treatment was available, and Pickering Platt were arguing whether to treat it or not. I give this example to the patients who are really resistant to suggestion. You know what you can do? It is very important to say that and also the doctor colleagues, that if education is all life education, if it is true, it is most true for the doctors. We have to march with the times, with the new knowledge. Therefore, for me, not prescribing a statin, I'm making it clear for your first question, for the prevention, primary prevention is of paramount importance. Therefore, not prescribing a statin in the appropriate doses for primary prevention is criminality. Therefore, and I do not believe that there are any serious side effect except stray incidents which can occur. And people stop statin because they think that they're all right, they don't want it. And we have already discussed, I don't waste time on that. But I like to mention that when the drug was reintroduced, as you just now heard, they tolerated drug very well. So they have just left it by way of some influence by others, or etc., etc. Therefore, to me, my dear friend, statins are wonderful. They have to be taken, not prescribe it when it is indicated, like for primary prevention. Secondary prevention has been discussed again and again. It is a crime. And it is our august duty to prescribe it properly in the proper doses. Today's world, as you rightly said at the very beginning, Crevast has become affordable. Many drugs, for that matter, in their doses, affordable, they're appropriate, they're available and accessible. Not to prescribe it is no more an option.
Thank you, Dr. Das. So I would probably end with very interesting demands from patients. These are patients' suggestions how to improve adherence to statin therapy. So it is one-sided. I would allow the readers to read rather than enumerate. You can also read. We would not have a discussion on what patients can demand. Patients will continue to demand much more than what they deserve, and they still may not do it. That's why paramedics and others take up a health education position in every doctor's clinic. I don't think doctor can continue to talk and talk and talk, because patients don't pay per unit time spent by a doctor. So many times in a very busy clinic, many doctors tend to neglect every small aspect of an education. But in many chronic therapy, chronic disease management, some talking is really necessary.
Absolutely. And I think these observations that you have focused are revealing. You were not going through it. They're revealing. I don't know where you got it, Sanjeev. That's your specialty. They're revealing and they're quite interesting. And it also gives what the psychology of the patient demands from us. We must rise to the occasion.
I think the most important slide in the whole presentation was this.
Yes, very interesting. I really liked it very, very much, Sanjeev. I think good, absolutely fabulous. I agree with Govind. Ramesh, good.
I think reminder is a very easy thing now in a digital world. We have been doing for asthma patient these reminders, epilepsy patient, and I think that has worked some extent. They improve the compliance and the adherence to some extent. I think that can have a meaning, and the pharma industry can help us in this case. The reminders, at least, that is one thing. And Sanjeev, one more thing I want to ask you: are doing a data of the 12,000 patient by areas. What is the initial outcome that you just very interesting thing what you're talking about? Is it something which maybe final data may come? What is the important?
No, it's not a patient. It's a 12,000.
12 doctors, physicians, as you said, actually.
Yeah, the
We
doctor.
had done the vitamin D data. Initially, 90% of people are deficient. That's very surprising data came when the vitamin D came in the market, actually, remember.
So this is a severe risk. And these are not surgeons, orthopedic or OBGY.
Physicians properly.
Only physician, MD physicians and diabetologists to whom Aries team meets, and cardiologists and all others. So across the country, and the average age was not very, very high. There are people who are younger also, the mean age we would see, but the risk factor burden is significantly high, even in the physicians. So physicians might need also the lifestyle intervention as well as the medications as per their risk factor. They are also equally difficult patients. All of us must have experienced when doctor becomes a patient is similarly as difficult as any other patient. So this was just a last 2 months evaluation. The team, which is with a dapagliflozin and a Gluxid brand, has taken up that kind of an activity, and they are going to have further continuous workup on patients. But on physician, the intention is to have year after year for 10 years with the same doctors to be evaluated for 10 years. Whether the risk goes down or not, by an actual intervention is to be seen.
12,000 is a very big number, actually, I think, to achieve a national something. I think the outcome
Correct.
actually helpful to have put a number.
I should remember a similar paper Ramachandran published, but with much less number. It was about less than 1,000 people. He titled the paper "Physician, Heal Thyself." But I think, Sanjeev, the most important thing we are focused now, that you have to do these points what patient want from us. Do it by hook or by crook or by hook and crook. Thank you.
So with this, I would end today's session on Crevast Academy. I would thank all three experts for joining this evening, Dr. Govindan, Dr. Ramesh Dargad, and Dr. Ashok Kumar Das. And I would thank Aris for giving me an opportunity to run as the moderator in a lipid series
Excellent
for
job.
the last whole year.
You have done excellent job, Sanjeev. I think both are
Very nicely done. Very nice.
Fabulous
Thank
job.
you. Thank you all for joining.
Thank
Later
you
on,
very
you will
much.
get the message how many doctors had joined today. Thank you all.
Thank you.
Enjoy weekend.